Casual service in the advanced hospitals have a dental team. It is comprised with dental and oral maxillofacial emergencies. So, as specialists, dental surgeons are most qualified to diagnose and treat traumas and diseases of the mouth, face, and neck. They should involve themselves actively in the casualty service of the hospital. On-call. On-call describes that the duty doctor or the resident medical officer should be available to provide emergency care for the sick in the casualty department or inpatient consultation. So, in other words, it is someone that is ready to respond or on duty at the time of emergency. So, resident dentists or maxillofacial surgeons on call may be available either by physical presence in the hospital, which is preferred form of on-call, and pager or phone call at home. It is undesirable form for many reasons. For example, the casualty staff may not call the resident dentist at all because such a method of contact takes too long to get the help needed. The first interventions performed in the casualty are the following: establish and maintain patent airway, control of bleeding, prevention of shock. So this will be elaborated in the next slides. The oral and maxillofacial surgeons have traditionally been the first dental professionals called to provide casualty consultations. They provide advice and care for a multitude of problems. Below are the followings. Injuries of the maxillofacial region. Face is the most prominent, attractive, and expressive part of human body. Since it is very prominent, it is easily subjected to trauma. Hence, it is mandatory that the on-call casualty dental surgeon also be aware of the basics of management of maxillofacial injuries. Golden hour. It is commonly used to characterize the urgent need for the care of trauma patients. This term implies the morbidity and mortality are affected if care is not instituted within the first hour after injury. So mortality from trauma has a trimodal distribution: first peak, second peak, and third peak. So what is first peak? First peak is, as you can see here, is within seconds to minutes of the event. It is a degree of injury sustained in such that survival is only a remote possibility even in the most optimal circumstances. So death in this group is due to the severe injury to brain and major cardiovascular structures such as the heart and great vessels. Second peak. It is within some minutes to a few hours after the event. Death in this group is attributed to unrecognized serious complications such as airway and ventilatory compromise, hemorrhage, and head injury. This second peak of mortality is amenable to active professional intervention and is referred to as the golden hour of saving the life of the patient. Third peak. It is within days to weeks after the event, when multi-organ failure and sepsis leads to death. This is often occurs as a result of inadequate treatment in the golden hour. Maxillofacial injuries includes the injuries of the middle third or the lower one-third of the facial skeleton. So there are two important factors that can lead to the death of the patient. As you can see here, number one is respiratory obstruction, and number two is massive hemorrhage leading to shock. So later on, we will talk about it in depth. Respiratory obstruction. So there are a lot of things that can obstruct the nasal and oral airway, and it could be by blood clot, vomitus, saliva, bone, teeth, dentures, and foreign bodies. So number two, in bilateral parasymphysial fractures of the mandible, a bodily backward displacement of the tongue and its attachment can lead to disclosure of both the nasopharynx and oropharynx. Number three, a downward and backward displacement of the fractured maxilla can occlude the oronasopharynx. 4. Airway obstruction may occur as a result of large hematoma formation in the floor of the mouth or due to pharyngeal or laryngeal edema or surgical emphysema. Management of airway obstruction. Number 1, clearing the oro and nasopharynx. How to do that? So, under a good vision, the mouth should be examined and cleared from blood clots, mucus, broken teeth, dentures, or other foreign bodies. with the help of a powerful suction and wet swabs. 2. If the tongue falls backward, it should be brought bodily forward. Number 3. By forcibly impacting the maxilla. This is done by passing the index and middle fingers into the mouth with the tips hooked behind and above the soft palate into the posterior nasal opening, and with the thumb placed on the alveolus in the incisal region. Number 4. In a patient with maxillofacial injury, the semi-prone or lateral position is preferable. This will maintain a clear airway by allowing drainage or blood, saliva, and CSF from the airway and preventing partially avulsed soft tissue of the lips or cheeks from obstructing the airway. If the airway is becoming considerably compromised or the obstruction is increasing, then an endotracheal intubation should be carried out. Number 6. In certain situations, a tracheostomy has to be done to secure a clear airway in an extreme emergency situation. Laryngectomy, where a percutaneous incision of the cricothyroid membrane is done. Know about the hemorrhage in the maxillofacial region. So, number 1, severe hemorrhage associated with soft tissue laceration is rare in the maxillofacial region. Number 2, severe bleeding from the inferior alveolar artery. An immediate open reduction and control of bleeding should be carried out. Number 3, severe bleeding from the palatine vessels can be controlled by inserting a deep suture down the bone to include the vessels and the mucoperiosteum in a single bite. Shock. Though the bleeding from the facial injuries can be considerable, very rarely they are the sole cause for a systemic shock. The rare instance being extensive soft tissue injuries involving large blood vessels in the neck. Signs of shock. Shock in the maxillofacial injuries is always due to the hypovolemia and characterized by cold skin, increase in respiratory rate, tachycardia, hypotension, and dilation of pupils.
Good day all, this is Maria Pedregosa and I will be continuing the report. First, I will be starting with the clinical examination of the maxillofacial region. After stabilizing the patient, first you would have to get the patient's history of injury. A detailed history regarding the injury should be obtained either from the patient if he is conscious and well-oriented, or from the companions and reliable witnesses. First, you would have to get the date and time of the injury. It is important from the clinical point of view to know whether it is a recent injury or an old injury, and this will give a clue regarding the infection of the site of the fracture, and this information is important for medical legal purposes. The second would be you would have to get the mode of injury. Knowing the magnitude and direction of impact may give an indication regarding the possible extent and pattern of injury. Next would be checking the patient's history regarding level of consciousness. Evaluating the level of consciousness is the most important step in assessing cerebral damage. The degree and duration of loss of consciousness indicate the amount of cerebral damage. Inability to remember the events leading up to the accident is called pre-traumatic retrograde amnesia. From this, you can determine how much cerebral damage the patient had, and then you can observe and foresee what would be the possible effects of that to the patient. Next would be taking the history of treatment prior to admission. This is usually done by the first aid, and then you would have to know what were the procedures done for the first aid to the patient. You would have to know details of the drugs taken, like prophylaxis against tetanus, antibiotic therapy, and intake of certain drugs like morphine. It should be obtained from the patient's record. Second is the general examination. A general systemic examination of the patient is very essential prior to the local examination of the maxillofacial region to exclude the possibilities of more serious injuries elsewhere in the body. First, the cranium or the head should be inspected and palpated for soft tissue lacerations and bony damages. They would have to check for cuts or, like mentioned, lacerations. The level of consciousness should also be determined and the patient graded as clear, confused, and disoriented. This time, if the patient is conscious, you would have to ask the patient if he is clear, is he confused about the situation, or disoriented. Next, you should check the eyes. You should look for any injury to the globe. Effort should be made to record the vision, pupillary size, and the reaction of illumination. This will be used with the penlight. Progressive dilatation of pupil and loss of reaction to light is an indication of increase in intracranial pressure. A fixed dilatation of pupil is a sign of oculomotor paralysis. Next will be checked is the ear and nose. This will be checked for bleeding or any cerebrospinal fluid leak. In patients with stiff neck, following the trauma, an injury to the cervical spine would be suspected. The whole spinal cord should be palpated, and whenever a spinal injury is suspected, it should be confirmed with a suitable radiograph. Next check is the chest and abdomen. Be inspected and palpated to determine any injury to the thoracic cage and injury to the viscera and the other organs in the abdomen. Finally, all the limbs should be palpated and for tenderness and deformity. Second is the general examination. Next is the local examination. Following a thorough general examination and institution of any emergency and resuscitation measure, examination is focused on the detailed assessment of local injuries to the maxillofacial region. Prior to the commencement of examination, face and mouth should be carefully cleared of blood clots, road dirt, broken teeth, or dentures, or any other foreign bodies. This will facilitate proper examination and might reveal many obscured underlying soft tissue and hard tissue injuries. Examination of the mandible. Extraoral inspection. You're gonna be looking for presence of inflammatory swelling, ecchymosis, or soft tissue laceration is the common finding over a fractured site. A minor contour defect may not be noticed in the early period due to the presence of edema. When there is a gross displacement of fractured ends, it not only produces contour defect, but also the patient will have difficulty in opening and closing the mouth. A fracture in the teeth bearing area will always be compound into the oral cavity. In fresh injuries, there will be dribbling of blood-stained saliva from the corner of the mouth. Next is the examination of the maxilla. The premaxillary region is grasped with fingers of right hand and left hand thumb, and index finger is placed over the bridge of the nose and at the frontomaxillary and frontonasal junction, and upward pressure is exerted at the premaxillary region, which confirms the movement of the third facial skeleton. Injuries to the teeth are noted and carefully recorded. Teeth are examined to verify avulsion or loss, fracture, mobility, intrusion, and extrusion. If certain teeth are lost prior to the accident, and if the patient is wearing partial or full denture, that should also be mentioned in the records. Any loose teeth extracted following the trauma is noted. A neck and a chest radiograph may be taken if swallowing or aspiration of tooth is suspected. Next is the local fracture Fractures of the mandible. There are 5 types of classification. First, we have simple, compound, commuted, pathological, and green stick. The aim of any classification is to group the fractures separately from the purpose of diagnosis and treatment planning. Fractures occurring in the non-tooth-bearing areas are often simple, while fractures occurring in the tooth-bearing areas in the dentulous cases are compound in the tooth through the periodontal space. Fractures of the mandible. These are the most common classification of fractures of the mandible. First, we have the dentoalveolar, which is 1.4%. B, the condylar, which is 29.3%. C, the ramus in the coronoid, which is 4.8%. D, the angle, which is 23.1%. E, the body or the horizontal portion up to the premolar area, which is 33%, is considered the highest. F would be the symphysial region, which is 8.4%. These are the most common classification of fractures of the mandible. First, we have the dentoalveolar. Fractures of the mandible third of the face. Since the middle third of the face comprises of many bones joined together, it is rather more convenient to classify these fractures on an anatomical basis rather than taking them individually. So these are the classifications. First, we have nasal complex fractures. Second is we have the zygomatic complex fractures, including the orbit. Third is the dentoalveolar fractures. Fourth is the Lefort-1 fracture. Lefort-1 fracture is a horizontal maxillary fracture separating the teeth from the upper face, or it's also known as the Guerin fracture. Lefort type 2 is the pyramidal fracture with the teeth at the pyramid base and nasofrontal suture at its apex. Lefort type 3, a craniofacial disjunction. It transverses through the nasofrontal suture, the maxillofrontal suture, orbital wall, and zygomatic suture. So basically, Lefort 1 is a floating palate, horizontal. Lefort 2 is a floating maxilla, which is pyramidal. Lefort 3 is a floating face, which is transverse. Fracture. This is for the radiology of the facial injuries. A thorough knowledge of the surgical anatomy and a meticulous clinical examination usually enable the examiner to come to an accurate diagnosis of the fractures of the maxillofacial region. Many a time, clinical examination should be considered more valuable than radiologic investigation. The multiplicity and overlapping of the bony structures with associated air spaces may confuse the radiological diagnosis of fractures in the maxillofacial region. Radiographs are essential for a few reasons though. There are certain fractures which cannot be properly understood by clinical examinations alone. When edema and emphysema has set in, it is not easy to pinpoint the fracture sites. Moreover, in medical legal purposes, x-rays are needed. Basically, radiology or radiographs are needed for examinations to further help in the investigation of the case. This is for the radiology. Under the radiology of facial injuries, these are just some of the radiographic views that are useful in the diagnosis of fractures of the skeleton. First, we have the postero-anterior view of the skull and mandible. Second is we have the right and left lateral oblique view of mandible. Third, we have the paranasal sinus view of maxilla. Fourth, we have the orthopantomogram. or the OPG. Fifth, we have the occlusal and periapical radiographs, which is pretty common. And then sixth, we have CT scans in fractures of the middle third of the face. Under the radiology, in the modern practice, no mid-face trauma should be treated until there is a CT scan. The CT scan is the best instrument available to demonstrate the extent of these four major types of facial bone fractures. First, the Lefort fractures. Second, the solitary blow out fractures of the orbit. Third, we have the zygomatio-maxillary fractures. Fourth, we have the nasal bone fractures. In the modern definitive treatment of maxillofacial fractures. For the principles of treatment of the bony injuries, the basic principles are reduction, fixation, and immobilization. However, the injury to the surrounding tissues should also be taken into consideration, and the bony injury should be taken as part of the total wounding process. It should be remembered that bone healing is better where healthy tissues surround the injured bone. Basically, if the patient gets an early treatment, it would have a better result. If the injury has a healthy soft tissue covering it, there's better bone healing. If the face has abundant supply of blood, there will be minimum debridement done. If there is a teeth in the fracture line, each case should be considered individually. Because in some cases, if you remove the teeth, it could actually be more damaging to the fracture itself. So that is why it is mentioned that it is a case-to-case basis. Definitive treatment of maxillofacial injuries. Under the facial lacerations should be treated as soon as possible. The goal is to stabilize the patient condition first. And then, during the procedure, a layer-by-layer closure by identifying the deepest layer and closing it first will be done. Usually, facial lacerations may damage important structures such as the parotid duct, endofacial, and the trigeminal nerves. Length and depth of lacerations and the size of abrasion, contusion, and hematoma should be recorded carefully for medico-legal purposes again. Definitive
Now let's proceed to the definitive treatment of fracture mandible. So commonly used methods of reduction and fixation of fracture mandible includes two procedures. First, we have close reduction and indirect skeletal fixation. So it includes dental wiring, which can be direct, eyelet, or IV loop, and then arch bars, cap splints, gunning type splints, and pin fixation. Now, the second one, we have open reduction and direct skeletal fixation. So there are 5. First, we have transosseous wiring or osteocentesis, bone plating, which includes 2, mini plating and compression plating, use of lag screws, bone staples, and bone clamps. Next, we have definitive management of middle third fractures. So, the line of management in middle third fracture is basically the same as in other fractures, reduction and fixation. So, the middle third comprise of a number of slender bony struts directed towards the base of the skull. So, the fixation in mandibular fractures can be attained by fixing the mandible to the maxilla, because the maxilla forms a stable structure. However, in the middle third fractures, it cannot be fixed in the mandible alone, for the mandible is a mobile structure capable of movement. There are methods devised for a proper fixation of fractures maxillary complex which are divided into two. We have the extraoral immobilization and the immobilization within the tissues. So we have the transosseous wiring, bone plate osteosynthesis, transfixation using Kirschner wire, internal wire suspension. Now let's go to the duration of the treatment. So it varies depending on the site of fracture, condition of each case, and treatment modality. As a general rule, the maxillary mandibular fixation has to be kept in position for a period of 3 to 4 weeks in children and adolescents. So for the adults, it should be 5 to 6 weeks, and in old patients and in infected cases, the period of fixation has to be increased for 7 to 10 days more. Management of head injury. For the assessment of head injuries, so we have to take first history. To make the correct management decisions, it is helpful to know what kind of head injury can result from a certain kind of trauma. For example, simply knowing that the patient was injured in fall instead of a vehicular crash increases the patient's risk of having an intracranial hematoma. Next, the initial assessment provides the baseline for sequential reassessment, which is the critical basis for subsequent decisions in management. We also need to assess the vital signs. In the presence of hypotension, always look for other injuries like abdominal or thoracic injury. Although bleeding from scalp lacerations can cause hemorrhagic shock in small children, intracranial bleeding will not produce shock from blood loss alone. The combination of progressive hypertension associated with bradycardia and diminished respiratory rate is a specific response to an acute and potentially lethal rise in intracranial pressure. Such cases may require immediate neurosurgical intervention. Now for this mini neurological examination, it is directed towards determining the presence or severity of gross neurologic deficits, especially those that may require urgent surgical intervention. So the examination assesses the level of consciousness, pupillary function, and lateralized extremity weakness. Generally, a patient with abnormalities of all these three components will have a mass lesion that may require surgery. Now let's proceed to the special assessment. Skull X-rays are of little value in the early management of patients with obvious head injuries except in cases of penetrating injuries. The unconscious patient should have skull X-rays only if the care of the cardiorespiratory status system is assured. We also have CT scan, which has revolutionized the diagnosis and management of head injury and is the diagnostic procedure of choice for patients who have serious head injury. It should be remembered that CT scan should be done only after the initial resuscitation is completed and adequate resuscitation should be maintained during the scan. Here's a picture showing a radiopacity on the right side corner which shows extradural hematoma. These are the emergency management of head injury. The initial management principle of any trauma case applies to head injured patients also. This included airway management, maintenance of breathing and circulation. Keeping airway patent should be the first priority in the management of head injury. After assessing the vital signs, if the patient is hypotensive, Look for other injuries and a neurologic assessment, and investigations need to be done only after stabilizing the hemodynamic status of the patient. It is better to avoid giving hyposmolar solutions like glucose drip to patients with head injury. The recommended fluid is Ringer lactate or normal saline. Head injury is often associated with cervical injury also, and a cervical collar may be advised. Examination of a head injury patient is never complete without proper examination of the neck. Perform the mini neurological examination and arrive at a working diagnosis. It is important to decide whether the patient requires a neurosurgical intervention. Scalp injuries are seen in most of the head injuries. The first priority in management of scalp wound should be locating and stopping the bleeding. Simple scalp suturing with irrigation with copious amount of saline should be done before reference. In cases of raised intracranial tension, where surgical intervention is not needed or deferred, patients can be put on intravenous mannitol. The suggested dosage is 150 ml of 20% solution every 4 to 6 hourly through a large gauge needle, and the fluid should run in 10 to 15 minutes. Seizures can occur with any type of head injury. In most cases, seizures are well controlled with phenytoin 100 mg intravenously repeated every 8 hours. Restlessness frequently accompanies head trauma. Its development in a previously quiet patient may be first sign of a developing intracranial mass lesion. Hyperthermia is disastrous to a patient with brain injury. This will increase the brain metabolism and brain edema. Temperature should always be kept below 90 degrees Fahrenheit. Antibiotics are indicated in presence of basal skull fracture, compound vault fracture, and suspected or proven meningitis. Pain is controlled with simple analgesics like paracetamol. For fear of respiratory depression and change in the level of consciousness, opiates are better avoided. Lastly, head injury patients often suffer from gastrointestinal bleeding. So that's all for this chapter. Thank you for listening and have a good day.